Well, good evening, everyone. Good to see so many people are joining us right now for our webinar about the undescended testis. My name is Lammers. I will be one of the hosts for tonight. And we'll first start off with an introduction. So we are with 5 people this evening. We will start off with Guy Bogaert. He is a professor of Paediatric Urology in Leuven, Belgium, and he's one of the EAU Guideline members. Our other speaker is Numan Baydilli. He's an associate professor at Ergici University in Turkey and also a EAU member. And our third speaker of tonight is Uchenna Kennedy. She is a pediatric surgeon, pediatric urologist at Zurich in Switzerland, and an associate guideline member for the EAU guidelines on pediatric urology. I'm hosting together with Irfan Dönmez. He's an associate professor in Istanbul, Turkey. He's also a EAU member and a member of the research committee of the ESPU Congress. And my name is Rianne Lammers. I work as a pediatric urologist in the University of Medical Center in Groningen, that's in the Netherlands. And I'm a EAU member and a member of the educational committee of the ESPU. So we have no conflict of interest. And the reason we started with the idea of this webinar is because with the EAU, the Young Academic Urologists, we have recently published 2 roundtables about the undescended testis, in which we discussed cases with experts all over the world, and they shared their differences about the clinical practice. And currently we are working on a manuscript in which we did a survey in over 250 people around the world about their differences in how to manage the undescended testis. And that's a publication to be. So we don't go into detail that yet, but that's the background of this webinar. So now I will hand over the presentation to Numan, and he will give us an introduction in the current guidelines about the undescended testis.
Hello everyone, I am Numan Baydilli from Kayseri. Today I'm going to present on the management of undescended testis based on EAU guidelines. First of all, I would like to thank the organization committee for this important talk. I have no conflict of interest report. EAU guidelines is freely available on the website. You can download the latest version here. Undescended testis or cryptorchidism is one of the most common congenital anomalies in males. The incidence varies according to gestational age. While the incidence in term infants is 1 to 4.6% at birth, it can increase to 45% in preterm infants. It is seen as approximately 1% at the end of the first year. It also may affect both sides in up to 30 of cases. Undescended testis can lead to serious health problems over time, especially infertility and testicular cancer. Additionally, torsion, hernia, and psychosocial factors and cosmetic concerns. Classification can be easily performed with a careful physical examination as palpable or non-palpable. The rate of palpable testis is fortunately quite high, around 8%. If the testis is palpable, it confirms the presence of a testis, which may be arrested along its descent pathway, ectopic or retracted. Non-palpable testis are seen 20%. Approximately half of the non-palpable testis are intra-abdominal, canaliculae or peeping. The remaining are absent or atrophic. The diagnosis needs to be confirmed once the child is under general anesthesia. The other type is acute undescended testis can result from entrapment after herniography or splenectomy. This diagram provides a nice summary of the topic. Diagnosis involves three main components: patient history, physical examination, and in specific cases, imaging. Let's start by looking at them. When taking a history for undescended testis, it is essential to consider premature birth and low birth weight. Maternal and paternal risk factors, such as hormonal exposure during pregnancy or any genetic or hormonal disorders, may influence testicular development. Next, we ask about any history of previous descended testis, as this could indicate retractile testis or other conditions. Finally, it's important any previous inguinal surgeries, as they can sometimes be associated with undescended or damaged testis. The most important step in the diagnosis is physical examination. When performed carefully, it provides critical and valuable information. Before starting the testicular examination, we should make sure a comfortable environment in the room. Our hands should be warm enough to minimize the cremasteric reflex, and the child position should be appropriate. We need to carefully check the testis in the scrotum, in the inguinal canal, or an ectopic site. If the testis cannot be felt, we should first evaluate possible ectopic locations. If no ectopic testis is identified, we consider intra-abdominal, canonical, or even absent scenarios. It is important to evaluate the size of the testis to determine whether it's normal or shows nubbin or atrophy. In unilateral cases, we should always examine the contralateral testis. Briefly, during the palpation, it's important to gently apply pressure above the groin and carefully sweep downward. Using a lubricant can also be helpful to make the examination smoother. If the testis is located, it should be gently guided to the scrotum and held there a moment. If the testis quickly retracts upward, the diagnosis is confirmed. In case of retractile testis and overactive cremasteric reflexes observed, while testis size and scrotum are normal. However, in undescended testis, unilateral scrotal atrophy is noticeable. When the test is non-palpable, we must carefully consider the potential ectopic location. You see at the right image an ectopic perineal testis. In the event of bilateral undescended testis and any evidence of sign of sexual development disorders such as micropenis, proximal hypospadias, or scrotal hyperpigmentation, further evaluation including endocrinologic and genetic assessment becomes mandatory. The last diagnostic method is imaging. Imaging methods such as ultrasound and MRI are not recommended for routine use in the evaluation. They are only indicated in specific situations, such as in obese children, cases where the physical examinations are not feasible, or there are signs of any disorders of sex development to evaluate Mullerian structures. Treatment should begin by 6 months of age and be completed by 12 to 18 months. This timeline is critical for preserving fertility potential and reducing the malignancy risk. Treatments generally consist of medical therapy, surgical intervention, or sometimes the combination of both. Hormonal therapy in undescended testis is now given to protect fertility, rather than to bring the testis down. The guideline recommended the hormonal therapy only children with bilateral undescended testis to preserve fertility in later life. It is stated that gonadotropin-releasing hormone is superior to promoting germ cell development. A typical dosage is 1 to 1.2 mg per day divided into 3 doses administered for 3-4 weeks. Still, there is no consensus on the use of hormonal treatment. In surgical treatments, palpable testes are operated using scrotal or inguinal approach. Scrotal approach is used for low-positioned palpable undescended testes, but inguinal orchiopexy is widely used technique with high success rate. For non-palpable testis, treatment is planned based on the testis presence and location found during laparoscopy. The first step is to perform a re-examination under anesthesia. If the testis is palpable, we shall do orchiopexy. If the testis is non-palpable, the next step is diagnostic laparoscopy to determine whether the testis is present or not. You may choose to start with inguinal orchiopexy in this stage and use laparoscopy only if necessary to avoid unnecessary procedures. If the testis is close to inguinal canal, a laparoscopic or inguinal orchiopexy can be performed. If it is located more than 2 centimeters from the inguinal ring, Pavlov-Stephens procedures are recommended. Blind ending vessels indicate an intrauterine torsion and the procedure is discontinued. Finally, if the spermatic vessels are seen entering the inguinal canal, an inguinal exploration should be performed. What should we do after puberty? The guideline says that if the contralateral testis is normal, orchiectomy is recommended for postpubertal boys. What about infertility? In unilateral cases, fertility rates are lower while paternity rates remain normal, whereas in bilateral undescended testis, both fertility and paternity rates are reduced. Even if treated boys for undescended testis, they have a high risk of testicular malignancy. Swedish study shows that prepubertal orchiopexy decreases the testicular cancer risk. Regular screening and self-examination are recommended during the after puberty. The cancer risk increases 2.2 times if treated before age 13 and rises to 5.4 times if treated after the age 13. Thank you for your attention.
Well, let's continue with our case-based discussions. So let me share my screen first. All right. Perfect. Now, I would like to once again introduce Rian as my co-moderator. And also I would like to invite Guy, Uchenna, and Numan for the roundtable discussion. Perfect. So I'll start with our first case. A newborn boy is referred to your outpatient clinic due to a left-sided undescended testis, and the physical examination reveals the right testis is within the scrotum and it's of normal size. The left testis is easily palpated in the groin and possibly at the level of external inguinal canal. The penis is in normal size with a ventral located meatus and an intact ventral prepuce. So I would like to ask Guy if he would treat this boy right now, or he would wait for some time, and why would he wait for some time? And when he chooses to treat this child, what sort of techniques for treatment does he use? Does he use hormonal or does he use surgical techniques? And in case he uses a surgical approach, what would his ideal approach to the case, inguinal or scrotal? Guy, please.
Okay. Well, thank you very much. Actually, if I got to see a child, a newborn, around birth, I'm always extremely grateful for that, because right at birth, everything is genitally large and long. And I will clarify myself, at birth, a boy has a very high level of testosterone. And this is due to the fact that boys get a lot of FSH and LH from the mother, because these hormones need the mother to maintain her pregnancy. So FSH and LH are passing through the placenta and are actually stimulating the length of the spermatic cord, and of course will also induce the hormonal function of the testis. So you will see and you will find out in a newborn boy that he has a huge, large scrotum, and penis, and everything is large because he has a lot of testosterone. So actually, this is the best way and the best timing to be able to examine a boy and his testicles. So this, I hope, answer your question, that actually hormonally you can't really improve anything at this moment, because the boy should have everything by himself at that moment. What I also would suggest is that at that time, the parents are very worried, and that you actually explain to them that indeed there is a testicle that is not in the correct place at that moment, but that actually a boy with a unilateral normal descended testis, he will have a completely normal paternity rate later in life. You can also explain to the parents that actually there is no need for a very urgent surgery at this moment. So what I would suggest is to see this boy back around 6 months of age. I would tell the parents that the chance that something will change in this clinical situation is very low. So an undescended testis will very most probably stay that way during further development, because now when this boy will grow up, FSH and LH from mom will be no longer available. So actually testosterone and all kinds of stimulation will be much, much lower when this boy will be 3 months, 4 months, or even 6 months. So I remember there was a myth that, people would say, well, let's wait a little bit and let's give it a chance that a testicle would descend. But actually, if it's not there at birth, the chance will be very, very, very low that it will really spontaneously descend within the first year of life. So this is why I would recommend to see this boy clinically back around the age of 6 months. And I would indeed prepare the parents a little bit to say that probably he will need surgery. You asked me if I would approach from scrotal or inguinal. To be really honest, I would, let's say, from a standard way of procedure, recommend an inguinal approach because we have done a prospective study for a long time in undescended testis, and we had in more than 85% of all the cases that we still had a patent processus vaginalis. So I think it is really much better that you do an inguinal approach, allowing the surgeon to also dissect and transect the processus vaginalis up to the inner ring and actually close it and dissect it away from the testicular vessels and vas deferens. So that's why I would really recommend a standard inguinal procedure. I think also the age of 6 months is much stabler, much more stable for anesthesia procedure than you would do it in a newborn. And again, there is no need in doing that surgery that early. Numan described the chance of, let's say, malignancy development in an undescended testis. And I think there are quite some studies now that have shown that the incidence of a malignancy in an undescended testis has actually almost normalized if you would do the procedure before the age of 1. So there is no need to rush also within those months.
Perfect. Thank you very much for your answers. I would like to turn to Uchenna if she has any additional things to say. Uchenna, would you approach any differently for this case?
Yes, thank you for inviting me to this webinar. I actually agree with everything that Guy said. I would approach it, I would have the same timing and also use the same surgical approach, because I think addressing the processes, which is usually patent in these small children, is easier with an inguinal approach. Maybe the only thing to add is that there is this phase between 2 and 6 months of life, the so-called mini puberty, where there is a gonadotropin and also testosterone surge. So in my understanding, that is the reason for having the hope, which I agree is probably small, that there might be some additional testicular descent during this phase. And I would also see the family at about 6 months of age.
What would be your approach for surgery if you are going to approach with a surgical intervention for this kid? Inguinal or scrotal?
I would also use an inguinal approach. There are many new studies that show that the scrotal approach also has a very high success rate. In my mind, in the smaller children, I think it is easier to address a large processus vaginalis, which is usually present in these younger boys, from an inguinal approach rather than a scrotal approach.
Thank you very much. Numan, do you have anything else besides Uchenna and Guy?
Yeah, I'm agree the treatments because we need to wait mini puberty period. In this case, there is a possibility of spontaneous testicular descent within the first 6 months. During this period, we recommended close follow-up with regular physical examination to evaluate testis position, whether it is in the inguinal canal or near the scrotum. Maybe it can change my decision. For example, inguinal or scrotal approach. I think the other thing is, it is important to avoid early discussions about malignancy or infertility risk, as these may cause unnecessary anxiety for parents at this stage. if the testis does not descend by the 6-month surgical, I will plan the surgical intervention. Maybe I can choose a scrotal. Maybe I can choose inguinal. I will decide that these things at the end of the 6 months.
Perfect. Thank you very much. Now let's give the microphone to Rianne and proceed with our second case.
Thank you. Our second case, we would like primary to discuss with Uchenna, and afterwards we will also ask Numan and Guy about their opinion. The case number 2 is about a 6-month-old boy. He was brought in for evaluation for a right-sided non-palpable testis, which was discovered during a general practitioner's examination. We did physical examination as well. That showed that the left testis is of normal size and located in the scrotum, so good. And there was no palpable testis on the right side, with only a slight nodularity possibly detected. The penis is normal in size and in appearance. So, Uchenna, what's your opinion about imaging? Should we do that? And if we should do that, what should we do? Would you do, in this case, further evaluation for genetics or hormonally? And what would be your surgical approach in this case?
Thank you very much for this case presentation. So I'm going to start with a little bit of a controversial topic. These are the imaging studies. In general, the physical examination in this case scenario with a one-sided non-palpable testis is definitely the most important exam. And there is no imaging study that can give us 100% security on our diagnosis. In our clinic, we do perform an ultrasound, especially in the older boys where we have a non-palpable testis that are maybe a little bit overweight, with the thought of possibly finding a testicle in the groin that was previously non-palpable. However, I would say that this does not change our management, because our next diagnostic and therapeutic step would be to perform an exam under anesthesia, examine the patient again and see if the non-palpable testis becomes palpable. If this is not the case, then we will perform a diagnostic laparoscopy. Maybe I'm going to go to the further evaluation first before talking about the surgery. So as this boy has on the left side a normal sized testicle and also a normal appearance of his external genitalia, I do not think that any further hormonal or genetic workup is necessary. In the case of a very small penis or bilateral undescended testis with hypospadias, that would be another scenario. But here, with a normal sized penis and a descended testis on one side, we would not perform any additional evaluation.
Perfect.
And then finally,
sorry.
No, that's fine. Finally, for the surgical approach, I started this before. We would start with an exam under anesthesia. So if under anesthesia, where the cremasteric muscle is fully relaxed and we have the ideal circumstances to examine, and if the testicle could then be palpated in the groin, we will perform a standard inguinal orchidopexy. If the testicle is still non-palpable during the exam under anesthesia, then we would move to a diagnostic laparoscopy. And in the setting of a diagnostic laparoscopy, we have different scenarios that are possible again. So scenario number 1 is that there is a testicle that is usually located close to the internal inguinal ring. Then we could choose to perform a 1 or 2 stage laparoscopic approach. We usually perform a Fowler-Stevens approach, which would be a 2-stage procedure. If we find the gonadal vessels entering the inguinal ring and the inguinal ring is closed, then again we would have to explore the groin or do an inguinal exploration. And if we find blind ending vessels, then that would mean that this is a vanished testis and no further action is required. There is a discussion on whether in that scenario a prophylactic pexy of the contralateral side should be performed, but I think there is no clear evidence whether that is beneficial or not.
Perfect, thank you. So I hear you do an ultrasound, even in the non-palpable cases. If I'm correct, in the guidelines, the recommendation is not to do any no additional ultrasound, huh?
Exactly.
Yeah.
And mainly, we do not want all patients to undergo ultrasound examinations. I think in the setting of a specialized center where it might affect your management approach, you could do it. But as I said, the recommendation, you should not rely on the ultrasound. The recommendation is to do an exam under anesthesia and then proceed with whatever finding you have.
Thank you for enlightening that. Numan, what are your thoughts on this case?
Yeah, when taking history, you mentioned that in the physical examination, I think the confusing or key statement is slight nodularity was detected. I think this can change because it can be testis or atrophic nubbin or nothing. We don't know. Diagnostic laparoscopy is considered the gold standard for locating testis, especially when it is intra-abdominal or peeping. However, you mentioned that slight nodularity was detected with careful examination under anesthesia, mentioned Uchena. With careful examination under anesthesia, maybe we can find the testis. We can palpate. It can be palpable. And then for this reason, we can avoid to need for diagnostic laparoscopy to prevent an unnecessary invasive procedure. I will go like this step. I don't give any hormonal treatment in this evaluation. I don't, because we know that unilateral undescended testis need any genetic or hormonal requirement. When we mention about surgical approach, if the testis is palpable under anesthesia, I consider bringing down using an inguinal approach. If the testis is non-palpable on the physical examination, first I perform diagnostic laparoscopy after evaluating the ectopic localization, because sometimes it can skip out. This allows me, laparoscopy allows me assess the condition of the spermatic vessels and ductus deferens. You know that I mentioned in the guideline, there are a lot of scenarios. What can I do at that point? If the testis is present and located close to the inguinal ring, I prefer inguinal approach because we are familiar with inguinal approach. We can detach the inguinal attachment from the testis like this approach. If the testis is too high from the inguinal canal, I prefer two-stage Fowler-Stephens procedures to release the peritoneum and spermatic vessels.
Perfect. Thank you. Guy, do you have any short additional information for us you would like to share?
I think I would ask, the first thing is like, if the parents knew if at birth there were two testicles or none. Because Numan pointed out something about this nubbin thing, like, so it could also have been a, let's say, neonatal torsion and a secondary nubbin or something, because as I said in case one, at birth is the best way to diagnose. My second point I would like to share also with you is to find out if they, let's say, normal descended testicle is normal size or is maybe hypertrophic, which means, if it's a larger size, because I think also there some studies have shown, although you can't prove it, that it's, you can't make it a standard, that in a contralateral descended testis, which is larger in volume, you might have either an atrophic testis or a vanishing testis. I also agree with Numan that specifically in this case, when you feel a nubbin, I would really advocate for an inguinal approach, because even if in an abdominal testis, you can sort of surgically work your way up. And actually from the internal ring, you can do a wonderful laparoscopy as well, and do a Fowler-Stevens procedure, staged or unstaged. So that's my view.
Thank you. Then
Sorry, can I just add something? I would, this is really, I think, a question of taste, but I would not agree with the last statement, because I would rather choose a diagnostic laparoscopy, as I think it is sometimes difficult to distinguish a nubbin from thicker, testicular layers that could also sometimes be palpable. Of course, if you find a nubbin, it might be then an easy approach, but if you don't find anything clearly, you might still have to move on to laparoscopy. But I think it is also in the hand of the surgeon, of course, which approach they feel more comfortable with.
Thank you.
When I would like to comment, sorry about this. When I was a young fellow many years ago, I was with Barry Cogan in San Francisco, and we, laparoscopy was the fashion. So we did a lot of laparoscopies. Sorry. And actually, I think in about 2/3 of all laparoscopies that we've done for non-palpable testis, the answer was in the groin. So I presented it at the AUA, and John Duckett, the famous pediatric urologist from Philadelphia, came up to me and he said, wonderful study, but you put 2/3 of these children in unnecessary danger of an invasive procedure. And these are exactly also the words of Newman, which I think most answers you can find in the inguinal canal.
Perfect.
But it's a matter of taste, maybe, and experience.
Yeah, and this is exactly why we call this a case discussion, because there's a good discussion. So perfect. I think I can hand over back to Irfan for our last case.
Thank you very much, Rianne. So this is a transitional urology case, and this is a 19-year-old male from a rural area, and is referred to urology after an undescended testis was identified during a military service medical examination. The patient was not aware of it, and the testis is slightly reduced in volume and located within the inguinal canal. And time to time, the patient has some growing pain, but couldn't identify the real cause. And also the contralateral testis is in normal size and location. He's tenor stage 5, and his erections and ejaculations are reported to be normal. So I would like to point out to Numan if he would like to ask any additional tests, and if he would ask any additional tests, what would they be? Further, I would like to ask his treatment approach for this case.
Thank you, Irfan, for this challenging question, because we see the patients after puberty, 19 years old male and inguinal undescended testis. In additional tests, routine imaging is not generally necessary for a palpable inguinal testis, but this patient has occasional growing. This is, I think, it can be important. According to the guidelines, imaging may be used when malignancy is suspected due to symptoms such as pain or the irregularity. In this case, the testicular ultrasound should be performed to check the potential issues such as testicular cancer or any heterogeneity in the testicular parenchyma. Or maybe the pain results from hernia, we don't know. Additionally, it's important to check the tumor markers, alpha photoprotein, beta HGG, and LDH for the rule out testicular cancer. The other point, additional, what can we test in these patients? If the patient has concerns about fertility, it would be appropriate to evaluate fertility status with a semen analysis. You said that normal ejaculation, normal erection, because I want to see the testicular semen analysis, semen profile. The normal size of the contralateral testis is a positive indicator for fertility. It's a chance maybe. We know that in unilateral cases, while fertility may be reduced, paternity rates are similar to those to general population. We know that. This is good knowledge, I think. If concerns persist, we can suggest sperm freezing to preserve his ability to have children in the future. We can decide this additional test according to patient's preference. When we skip the treatment approach, this testis is located in the inguinal canal and 19 years old. This is concerning because after puberty, the testicular cancer risk increases. That's why our main recommendation is orchiectomy. At this stage, bringing it down to the scrotum does not provide any benefit, and removing it helps eliminate the cancer risk. I prefer inguinal orchiectomy in this case. Additionally, sometimes we can offer our patients, we can also offer a testicular prosthesis. This is improve the appearance and help the patients feel better emotional, which is especially important in this age. Sometimes it could be important. In conclusion, orchiectomy is recommended to reduce malignancy risk with the option of simultaneous testicular prosthesis placement to address cosmetic concerns, I think.
Thank you very much, Numan. I would like to ask Guy, knowing a little bit of his approach for this, which might be a little bit different than Numan's. Guy, what would you like to say about it?
Yeah. Oh my God. Yeah, I would not take away this testicle in this man. No way. I think the chance, to be really honest, I may be a little bit provocative, but the chance that he will develop a cancer in this testicle is probably lower than the chance that he will lose his normal testicle from a trauma. He can lose his testicle, his normal testicle, and then he only has a prosthesis. So I'm provocative, but I think it's our task as a pediatric urologist, as a urologist, to educate our patients and to say, okay, we're going to put this testicle down in the scrotum. We have to educate him that it's normal to have two testicles, and he has two testicles, and that he should preventively check his testicles once a while. If he wants, I would invite him to come, let's say, once a year, if he would feel more comfortable, that we would do and assess also clinically. But I don't think he needs any kind of semen analysis, because with one testicle, he will have a completely normal paternity chance. I would not put him under additional pressure or uncertainty about that.
I would like to ask one additional question. You said you would like to take the testicle then. Would you biopsy it? And if yes, what would be the ideal way? Would you do it like a frozen section, or you just take the biopsy from several places from testis, or just send it and wait for the final outcome, or you just don't take biopsy at all?
Yeah, I think it's a very good question, Irfan. Actually, in this case, I would also do an ultrasound, like Numan said. Preoperatively, you never know that he would have microlithiasis or something. But if he would have a normal parenchyma, I'm at the time of the surgery, you're able to look at the complete tunica albuginea, and I would not recommend to do any, let's say, blind testicular biopsy. If he has a normal parenchyma and a smooth tunica albuginea, I would not do it.
Thank you. Thank you very much. Uchenna, what do you think about it? Would you act any differently than Guy and Numan?
I would agree with Guy. I think we can really educate the patient, inform them about the increased cancer risk, but also inform them about the importance of self-examination. And I would also agree with performing an ultrasound, and depending, of course, if the ultrasound looks completely normal, then I would also not perform a biopsy, because I think there's always a chance that you could miss any carcinoma in situ or any in situ lesion, and maybe you would have a wrong sense of security if you do a biopsy and it's normal. However, it doesn't mean that the entire testicle is normal. I think the most important thing is a regular self-examination.
Thank you very much. Just a last one additional question to both of you, since you are advocating the orchidopexy. Do you share a percentage of actual carcinoma in situ or intratubular germ cell neoplasia or seminoma risk in this patient while you're discussing the patient on the treatment modalities? What would you say, Guy? Do you share the patient with the knowledge that there might be like a small percentage of cancer or intratubular germ cell neoplasia, or you just mention some sort of? I'm just curious about the how you talk to the patient. That's what I was asking.
Okay. Mm-hmm. It all depends again on the let's say the age. Of course, you know, you have to inform the patients, you have to educate the patient. But if you have like a little boy of, let's say, 1 year, there is no way, there is no reason for keep on screening them on a regularly basis. So I wouldn't do that. There is no need. I mean, I don't know, somebody ever told me, it was my mentor, he said, you know, if the chance that you should see all your patients you have done surgery for an undescended testis, you have nothing else to do for the rest of your life than to see them every year. You would not be able to see any new patients before you would even, you know, detect one with a testicular tumor.
Maybe just briefly, I think in this scenario where it's an adolescent, I would definitely discuss this. I don't know if the clear-cut numbers help, but I think it is important to say that there is a clear increase in the risk, but the overall risk, as Guy mentioned before, is still low in one patient's lifetime. And I think if you discuss this, then the patient would also realize how important it is to follow the recommendations.
Perfect. Thank you all. Numan, do you have anything
Yeah,
to say?
You mentioned about in these cases, he's coming from rural area, rural territory. I think this is important in some countries. You examine a patient, you treat, but you don't, he's not coming back a long time. He is 19 years old. He needs to come back again for their control. If we didn't remove the testis, it's very important topic. Just a point.
If he comes from a rural area, the chance of a trauma on his other testicle is higher than he will develop cancer.
Yeah, this is the other perspective, maybe.
Perfect. So I will lead to Rian for Q&A session.
Yes, thank you. So I think we have a very good interactive discussion. We have a lot of participants. We're now at 180 participants, so very good. Before we go to the Q&A, we can announce that the EAU guidelines have been updating their guidelines about the undescended testis. And I think Uchenna can enlighten us about the highlights of the new guidelines. So the floor is yours, Uchenna.
Yes, we actually updated this chapter specifically, so we've been discussing this topic a lot, and I think you can all look forward to the new guidelines, which will be out next year in 2025. There will be some more concrete recommendations on how to examine undescended testis. We also updated the information on surgical therapy regarding scrotal orchidopexy, and also some newer laparoscopic techniques, such as the Shehata technique, which has been studied quite extensively now in the last few years. And we also updated the recommendation on the management of post-pubertal testes. So there you can also read more going in the direction that Guy and I were speaking about. Rian, you're muted.
Thank you for pointing that out. So we have, I think, time for one question, and then we will have a wrap up with a take-home message. I've been keeping track of the Q&As, and one topic that comes to mind, comes along a lot, is about the retractile testis. We did not discuss that yet, so I think it's good to shortly point that out. So the retractile testis, the questions that came via the Q&As: how should you manage it? What are the key points for follow-up? And until how long should you do the follow-up? What age do you accept the retractile testis? And I would like to ask Numan about his opinion about this.
Yeah, retractile testis should be followed closely, especially during childhood, as some may descend properly as the child grows, while others may ascend into the inguinal canal or become truly undescended. When we talk about clinical examination, regular clinical assessment to check for change in the testis position, whether it remains within the scrotum or ascend again, it's very crucial. During a follow-up visit, it's important to examine the position of the testis at the different stages, especially during temperature variations, example cold, weather, anxiety, or other physical activity. In most cases, retractile testis resolve by the age of 5 or 6 years. However, the testis becomes persistently undescended after this age, or ascend frequently. The surgery may be indicated. We should follow up these patients to the puberty. The chromosteric reflex is important. The unilateral scrotal atrophy is important in the physical examination. And the other thing is parental education. Some parents are very anxietic, very confusing. If any need for surgical approach for these patients, sometimes waiting is very problematic for them. It's essential to inform parents about the importance of regular follow-up and self-examination, if possible. Explaining that some retractable testes can resolve, others may require. You can follow up in daily of life, I think.
And how does a regular follow-up is defined? Is it once a year, more often, less often?
Yeah, yearly the follow-up period is recommended.
Perfect.
Prooperative.
Guy, anything you would like to add for the retractile testis? Okay.
If, retractile testis, there are two ages before puberty who can turn a retractile testis into an ascending cryptorchidism. It's something we haven't mentioned today, which is between 6 and 7 years and between 11 and 12 years. So these are, let's say, the main ages for possibility of ascending testis. So I would recommend to check them just before puberty. But otherwise, most of them, they turn out to become really good and normal.
Perfect, thank you. So we're almost running out of time, so I think we're perfectly on time for the take-home message. Irfan, the floor is yours.
Thank you, Rian. So the take-home messages as per the current 2024 guidelines is that undescended testis is the most common congenital genital malformation, and there's a chance of spontaneous descent in the first 6 months of life, possibly due to mini-puberty. And hormonal treatment for testicular descent is not approved, whereas GnRH analogs can be offered for bilateral cases to improve fertility status. Also, surgery should be done no later than 2 years of age in order to reduce the risk of testicular cancer, as well as to improve fertility status as well. And imaging modalities are not reliable for location and or the presence of testis. Laparoscopic approach is the preferred choice for a non-palpable testis, and as we currently know, that the orchiectomy seems a safer alternative for postpubertal presented testis where there are no andrological problems, which might be amenable to change in the next year. So I would like to thank all our panelists for their wonderful and fruitful discussion. I would like to thank the EAU for organizing such a nice case-based roundtable discussion. And I would like to thank all of our members and all of our colleagues who has been with us today. Thank you very much.